Menopause marks the permanent cessation of ovarian follicular activity, resulting in the end of menstrual cycles. Biologically, it is the point at which the ovaries no longer produce sufficient estrogen and progesterone to sustain the regular endometrial shedding that defines a period. The transition typically occurs between ages 45 and 55, but can vary based on genetics, lifestyle, and health status. Think of the reproductive system as a seasonal cycle. The fertile spring of the reproductive years gives way to an autumn where the hormonal environment stabilizes at a lower baseline. This shift has systemic consequences because estrogen influences virtually every organ system, from bone metabolism to cardiovascular tone and brain neurotransmission. The primary etiology of menopause is the intrinsic aging of the ovarian reserve. Over a woman's lifespan, the finite pool of primordial follicles declines through atresia and ovulation, eventually leaving too few viable oocytes to sustain estrogen production. Secondary causes accelerate this depletion. Surgical oophorectomy removes the source outright. Chemotherapy and radiation damage DNA in ovarian cells. Autoimmune oophoritis leads to immune-mediated destruction, and certain genetic disorders such as Turner syndrome, Fragile X permutation, predispose to earlier follicular exhaustion. Environmental factors, such as heavy smoking, can also increase oxidative stress on ovarian tissue, effectively speeding up the battery discharge. When ovarian estrogen production falls, the hypothalamic pituitary gonadal axis loses its normal feedback loop. Lower estradiol removes inhibitory signals on the hypothalamus, causing irregular release of gonadotropin-releasing hormone, GnRH, and consequently fluctuating levels of follicle-stimulating hormone, FSH. The hypothalamus also houses the thermoregulatory center. Estrogen normally widens the thermoneutral zone. Its loss narrows this zone, making small internal temperature changes trigger a vasomotor response, hot flashes, and night sweats. Concurrently, estrogen deficiency reduces osteoblast activity, leading to bone loss. It alters lipid profiles, raising LDL, lowering HDL, elevating cardiovascular risk. And it modulates neurotransmitters, serotonin, dopamine, contributing to mood disturbances and cognitive fog. In the United States, roughly 1 to 2 million women transition through menopause annually. The median age of natural menopause is 51 years, with a typical range of 45 to 55 years. Approximately 5% experience early menopause before age 40, often linked to genetic, medical, or lifestyle factors, while about 1% have late menopause after age 55. Worldwide, demographic studies show similar age distributions, though nutrition, physical activity, and socioeconomic status can shift the average by a year or two. Racial and ethnic variations exist. For example, African American women tend to report earlier onset of vasomotor symptoms compared to Asian women, despite similar menopausal ages. The clinical picture of menopause is heterogeneous. The hallmark vasomotor symptoms, hot flashes, and night sweats result from abrupt peripheral vasodilation, often described as a burst of heat followed by profuse sweating. Mood changes, irritability, anxiety, mild depression arise from altered serotonin turnover. Genitourinary atrophy manifests as vaginal dryness, dyspareunia, and urinary urgency due to thinning of the epithelial lining. Musculoskeletal complaints include joint stiffness and myalgias, likely linked to estrogen's anti-inflammatory effects. Cognitive complaints such as word-finding difficulty and brain fog reflect subtle shifts in frontal lobe neurotransmission. Each symptom can be illustrated by a practical scenario. A woman in a meeting suddenly feels as if a fan has switched on, sweating profusely, then has to excuse herself to the restroom. Diagnosing menopause is principally clinical. The gold standard is the absence of menstrual bleeding for 12 consecutive months in a woman of typical age, after excluding other causes of amenorrhea, for example, pregnancy, thyroid disease, hyperprolactinemia. A focused history captures symptom patterns, duration, and severity. Physical examination assesses signs of estrogen deficiency, for example, vaginal atrophy, decreased bone density. Laboratory testing, serum FSH usually greater than 30 international units per liter and estradiol low, can corroborate the transition, but is not mandatory because levels fluctuate during perimenopause. When premature menopause less than 40 years is suspected, karyotype analysis and autoimmune panels may be ordered to identify underlying etiologies. Menopause is subdivided into 3 temporal phases for clinical management. Perimenopause spans the years of menstrual irregularity, often accompanied by intermittent vasomotor symptoms. Hormone levels are erratic, with FSH rising and estradiol fluctuating. Menopause itself is defined retrospectively as the point after 12 months of amenorrhea, marking the cessation of ovarian follicular activity. Postmenopause encompasses the subsequent decades, during which estrogen remains low, and long-term sequelae such as osteoporosis, cardiovascular disease, and urogenital atrophy become more prominent. Recognizing the stage guides therapeutic choices. For instance, hormone therapy is most effective when started in early postmenopause and is generally discouraged after age 60 or more than 10 years from onset. Lifestyle interventions are first line. Regular weight-bearing and resistance exercise preserves bone density. Aerobic activity improves mood and reduces hot flash frequency. A diet rich in calcium, 1,200 milligrams per day, and vitamin D, 800 to 1,000 international units per day, supports skeletal health. Behavioral strategies include dressing in layers, using portable fans, and maintaining a symptom diary to identify triggers, spicy foods, alcohol, stress. Hormone therapy, abbreviated HT, remains the most effective treatment for vasomotor symptoms and urogenital atrophy. Low-dose transdermal estradiol patches minimize hepatic first-pass metabolism, while adding micronized progesterone protects the endometrium in women with an intact uterus. Non-hormonal pharmacotherapies, selective serotonin reuptake inhibitors, for example, paroxetine, gabapentin, and clonidine, offer alternatives for women with contraindications to hormone therapy. Bone-preserving agents such as bisphosphonates, denosumab, or selective estrogen receptor modulators, abbreviated SERMs, are added when FRAX scores indicate high fracture risk. The therapeutic toolbox is selected based on symptom severity, comorbidities, personal risk tolerance, and patient preference. While the timing of natural menopause cannot be halted, its health impact can be mitigated. Maintaining a healthy body mass index, BMI less than 25 kilograms per square meter, reduces the likelihood of early ovarian failure and lessens vasomotor intensity. Smoking cessation is crucial. Each decade of smoking advances menopause by approximately 1 to 2 years and worsens hot flashes. Regular physical activity, greater than or equal to 150 minutes of moderate aerobic exercise per week, preserves bone mineral density and cardiovascular fitness. Adequate nutrition, emphasizing whole grains, fruits, vegetables, omega-3 fatty acids, and limited saturated fat, helps maintain lipid profiles. Annual health screenings, bone densitometry, lipid panels, blood pressure, act like routine vehicle maintenance, detecting early pathology that could be aggravated by estrogen loss. The long-term outlook for most women undergoing menopause is favorable. Vasomotor symptoms typically peak during the first 2 years post-menopause and decline for 70 to 80% of women within 5 years. However, the sustained estrogen deficit raises risk for osteoporosis, up to 2-fold increased fracture incidence and cardiometabolic disease, elevated LDL hypertension. With timely interventions, calcium and vitamin D supplementation, HT when appropriate, and lifestyle modifications, these risks can be substantially reduced. Psychological adaptation tends to improve as women adjust to new body norms, and quality of life scores often plateau or rise after the initial symptom burden subsides. The past decade has produced several breakthroughs in menopausal care. Low-dose estradiol transdermal patches now deliver steady plasma concentrations, minimizing peaks that precipitate hot flashes and reducing thrombotic risk compared with oral formulations. Novel SERMs such as basedoxyphene, combined with conjugated estrogens, protect bone without stimulating breast or uterine tissue. Emerging data link the gut microbiome composition to the severity of vasomotor symptoms. Probiotic strains such as Lactobacillus reuteri are being trialed as adjunctive therapy. Digital health platforms employing machine learning algorithms analyze daily symptom logs to predict flash patterns, allowing personalized lifestyle adjustments. Additionally, selective progesterone receptor modulators, SPRMS, are under investigation for safer endometrial protection in HT regimens.